Hello, my name is Michael Cummings, and I'm an internal medicine physician, and I belong to a group called Abbott Northwestern General Medicine Associates, and we're a group of about 30 physicians, and we serve as faculty for the internal medicine residency program at Abbott Northwestern Hospital. In addition, we also teach medical students. Along with that role, I also have my own panel of patients, and so we also practice medicine as well as teach it. And today's talk is going to be about high blood pressure. It's called Managing Hypertension, or Managing High Blood Pressure, rather, Understanding, Diagnosing, and Treating Hypertension. I always like to begin my talks with a quote, and today's quote comes from the philosopher Michael Oakeshott, who said, "Thought must have a starting place. It can have none better than a good definition. A good definition centers the mind." And so I want to begin this talk with sort of defining the terms. So what is blood pressure? Blood pressure is a measure of how forcefully your blood goes through your arteries. It is the pressure your circulating blood exerts against the walls of your arteries. So then what is high blood pressure? High blood pressure is a condition where the force of blood against your arterial walls over time is just too high. So then you would say, why do we care about high blood pressure? Well, it turns out we've been caring about high blood pressure for about 100 years. The first study that ever showed that high blood pressure was not a good thing came from the insurance industry. That's why I have this picture of the insurance building from New York City. And then I went back and actually read this study, and their conclusion was mortality increases rapidly with the increase in blood pressure over average. So for about 100 years, we've known that high blood pressure can result in bad things. And now we know 100 years later that the risk of dying goes up significantly as your blood pressure goes up. And it's almost logarithmic, as you can see from this chart here. But I want to point out blood pressure is a measurement, and an elevated blood pressure is not actually the disease we care about. We call it a biomarker of a syndrome of high blood pressure or hypertension. So remember, the number you see is not the disease. It's a reflection of something else. So what is hypertension? Basically, hypertension is a product of sustained high blood pressure, meaning you have to have high blood pressure over a long period of time, and then it causes damage. And it's a syndrome that eventually involves functional and structural abnormalities of the heart and the vasculature. So the heart changes. Your actually arteries change with time. And this results in premature morbidity and death. So the question always is, what level of blood pressure is too high? And that's really the million-dollar question all the time. You can never give one answer to that. Burton Rose, who was sort of the father of hypertension and kidney disease, said high blood pressure, and I love this definition, is the level of blood pressure at which investigation and management does more good than harm. More good than harm. Sometimes the right thing to do is not be overly aggressive with blood pressure. Your blood pressure that you have varies depending on the phase of your cardiac cycle. So when your heart contracts, your blood pressure is at its highest moment, and that's called systolic. And when it relaxes and is totally relaxed, it's the lowest blood pressure that you have, and that's called diastolic. So the question is, how do we measure blood pressure? Well, it turns out we can measure blood pressure in a number of different ways. You can do it invasively, which happens when someone's very sick in the hospital, and they actually insert a catheter into your artery, and that catheter has a monitor. Or you can do it non-invasively, which I think everyone here is familiar with. But it turns out non-invasively, there's two different ways we can do that. We can do it with a cuff, which we've all experienced when someone pumps up that cuff. Or there's a new inventions out there called cuffless ones. We'll talk about that briefly. And that one, your artery is not occluded. So there's two different ways you can measure one's blood pressure with a cuff. There's the oscillatory one, which we've all had done, and the oscillometric one, which is a newer way of measuring one's blood pressure with a cuff. Now, the oscillatory one, the one we used to do all the time, is when someone comes into the room, they put you a cuff on your arm and they pump it up until it gets pretty tight, and then they deflate it slowly. But they pump it up enough so that your blood flow is actually cut off for a while. Okay, and then they release the pressure slowly, and as the blood flow resumes, if you have a if you're listening, you can begin to hear sounds. And the first sound you hear is your systolic blood pressure. And then when the sounds, they gradually decrease. And once they stop, that's your diastolic blood pressure. Okay. So you're estimating the peak blood pressure and the lowest amount of blood pressure that you have with the traditional oscillatory method. The oscillometric one, which is a newer one, involves involves having we still put on the cuff, but we don't have to listen to it. And when your heart contracts, a pulse wave is created. And it turns out there's a small rise and fall in the volume of blood in your arteries and your limbs. And this produces these pulsations. And these waves are detected by the cuff as it's deflated. And then it results in oscillations in the cuff pressure. And this device is able to measure the pressure and the volume changes that are occurring. And the engineering of this is much beyond my understanding, but that's how the oscillometric uh, operation works. And then they use these algorithms to estimate your systolic and diastolic blood pressure. I want to point out that the cuff-based measurement is the gold standard. It's the basis of the entire story of hypertension. And this is how we first identified the condition I mentioned over 100 years ago. And to this day, it's how we make the diagnosis, how we treat the disease, and how we manage the condition. It's all based on cuff-based measurements. And this cuff-based measurement story has been a tremendous success. The diagnosis and treatment of high blood pressure or hypertension directed by cuff-based measurements has saved thousands of lives. In fact, right now, when we treat someone for hypertension, we reduce their chance of a stroke by about a third, or 35 to 40%. We reduce their chance of having a heart attack about 20 to 25%, and we reduce the chance of a new heart failure by about half. On the other hand, blood pressure is actually a continuous phenomenon. It never stops, all right? And taking one or two blood pressure measurements in the office, or just taking the occasional home blood pressure measurement, is not giving you necessarily an accurate understanding of what's going on in your body 24/7. In statistic language, it's a small sample size. So it turns out that office blood pressure measurements, when you come to see the doctor, is not necessarily that reflective of what's actually going on throughout the day. And same with some of your home blood pressure measurements. It doesn't actually reflect, we use the word, the 24-hour burden your heart, your arteries, your vasculature, the brain, and the kidney actually see if your blood pressure is high. Okay. It's only a fair estimate of the individual risk. If you'd study big populations, it's very good. But for the actual individual, it's not as accurate as one would think. And that's why to date, the 24-hour ambulatory blood pressure monitoring is the best to date. And that we do that in our clinic probably more than any other small clinic in the country. We've done well over 10,000 of this. And what happens is you come to our office, we put it on a cuff, and you wear it for a day, and that machine automatically goes off every 20 minutes while you're awake and every 30 minutes while you sleep. And so then you come back the next day and you turn it in, and we have about 40 readings we can look at. And that is the best predictor we can have of whether you have high blood pressure or not. And it's interesting, when you sleep, that may be the best predictor of bad things happening. And there's some evidence that there's bad cardiovascular growth and remodeling, which are not good things, appear to happen more often when you sleep. And therefore, if you could control someone's blood pressure while they sleep, we may be better to lower their risk of strokes and heart disease. And one of the problems when you get that office blood pressure measurement, or the one in the church basement or in public, is it results in the overdiagnosis and overtreatment of hypertension. We call that white coat. It's not, you don't really have high blood pressure, but also can result in underdiagnosing it and undertreatment. So that's why we like the 24-hour blood pressure study the best. And in our little group, we did a study and we looked at over 4,000 24-hour blood pressure measures in our clinic that we had done, and we compared them to their last office blood pressure measurement. And we found that the office blood pressure was inaccurate 40% of the time. Half the time it was overestimating their blood pressure, and the other half the time it was underestimating it. To date, all the big guidelines recommend you get a 24-hour ambulatory blood pressure measurement to accurately confirm the diagnosis of hypertension. Now I'm going to just briefly turn to cuffless blood pressure monitoring, and that's the newest thing that's everywhere that people are talking about. And I don't understand the engineering of this method either. But this, you just wear a little patch or device. And the nice thing about this potentially will be, it will be able to measure your blood pressure continuously for the entire day. So you can just imagine how this could be the future someday, because you're actually going to really get an accurate representation of the actual burden your body faces if your blood pressure is too high. And these wearable devices are able to estimate your blood pressure without inflating a cuff. And what they do is they're able to measure, we talked about that when your heart contracts, it creates a pulse, and we're able to measure how fast that pulse travels throughout your body. And they do these fancy things with pulse wave analysis, and they're able to sort of determine what the volume in your blood is. And through all that, they can actually calculate what your blood pressure would be. And these things these devices are currently approved, but they really haven't been validated. And we have no present way to actually standardize this process. So to date, we don't recommend we do that because we don't really know what to do with these numbers. Microsoft did this big project where they looked at all this, the technology of these new devices, and they determined that it was currently not clinically useful. I think someday this will be the future, but I don't think it's ready for prime time yet. So what causes hypertension? Well, what is the word we use, because we always want to sound like we know more than we do. The word we use is pathophysiology. What is the pathophysiology of hypertension? What are the changes that are occurring in your body that result in this sustained hypertension or high blood pressure? The dirty little secret is that the etiology and the genetic determinants remain very elusive. We've learned tons in the last 100 years, but we still don't really have a full picture of what goes on most of the time when someone has high blood pressure. Genetics, age, and the environment all contribute to the development of hypertension. But I will point out that it's primarily, for most people, it's genetics and age that play the biggest role in one's blood pressure. And if one lives long enough, almost everybody develops high blood pressure. And it turns out that hypertension has multiple etiologies. There's just not one type of hypertension, and it has a variety of different expressions. The word we use is phenotypes. So the idea that an 85-year-old woman has the same type of hypertension as a 25-year-old male is, on the face of it, not the same disease, but we think of them being the same, but they're not. And they have different etiologies and different physiology going on in their body. And it turns out there's all these different factors, and the interplay of these factors causing hypertension is infinitely complex. We have a very good understanding, but it's not the whole story. You never really know exactly what interplay is having the biggest role for your patient. So I like to go back to just, if you understand what blood pressure, what result, it's basically calculated from how much blood you have, the volume of blood you have in your body, and how tight your arteries are. We use the word vasoconstriction. And those are the two factors that go into determine the physics of your blood pressure. It's vasoconstriction times volume. Obviously, if you're bleeding and you're losing blood, your blood pressure will be low. Conversely, if you have too much volume, your blood pressure will be high. And in addition, if your arteries are dilated and super big, your blood pressure can potentially be too low, or if they're really tight, your blood pressure will be higher. The reason I point this out is because this is what directs the treatment of high blood pressure, is working on those two different variables. And the 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 function, your arteries, their ability to relax and dilate is what's affecting the vasoconstriction part. And the volume of your blood is what's impacting the volume of your blood. Now, I don't expect you guys to have to take a test and repeat this stuff back, but just know there's a system called the renin-angiotensin-aldosterone system. And this is a hormonal system that regulates your blood pressure by controlling how much sodium you absorb. And it also helps relax, it plays a role in determining how relaxed or not relaxed your blood vessels are. We're all familiar with the sympathetic nervous system. That's the fight thing when you get scared. Well, that increases blood pressure by releasing norepinephrine, which constricts your blood vessels and increases your heart rate. Also, your kidney, when it is damaged, is not as good at when it's impaired. It loses the ability to really efficiently get rid of sodium, and you end up having more sodium and more water. And finally, with aging, our vascular system, our arteries get stiffer and more narrow, and they lose their ability to relax, resulting in increased blood pressure. These are just four little ways of just thinking of how blood pressure can get high. It's more complex than that, but just it's good to get an understanding of the different ways why one might have high blood pressure. Like I said, there's more than one phenotype. Okay, so now I just want to talk a little bit about the treatment of hypertension. The first study that we ever had that showed that we actually can successfully treat high blood pressure was in 1967. So just think about that. Up to 1967, from 1925 to 1967, we knew that having high blood pressure was not a good thing, but we didn't know how to treat it. And this study, just to give you an idea where we were back in 1967, to enter this study, you had to have a diastolic blood pressure between 115 and 129. Okay. Well, normal diastolic blood pressure is less than 80. I've never seen anyone in my clinic with a diastolic blood pressure of 129. So we have two different ways we can treat high blood pressure. One is the non-pharmacological way, which we're going to talk about, which everyone wants to know. And then there's drug therapy. So let's go back to the physiology. Remember, blood pressure equals vasoconstriction times volume. And so the four ways that you can try to have some impact on your blood pressure is through weight loss. And primarily the reason why weight loss is effective, when you are overweight, you have much more volume in your blood system. And that increased volume results in high blood pressure. It turns out that people, when they have a super high sodium diet, that results in your kidneys absorbing more blood, and so you have a higher volume of blood. And exercise decreases blood pressure by making your heart more efficient and allows your blood vessels to relax better. And alcohol plays a role increasing one's blood pressure by it also increases vasoconstriction, but also you have more sodium absorption. And the point is not to try to remember these things. Just remember weight loss, a Mediterranean type diet with moderate, with trying not to have high sodium, exercise, and alcohol all play a role in one's blood pressure. But unfortunately, we can only reduce blood pressure so much through these ways, and ultimately most folks have to go on medications. Because remember, the physiology of high blood pressure is related more to what's going on in your body than external factors. You don't need to remember this, but we have basically four different types of medications that your doctor may give you. Probably the most common one are ACE inhibitors or ARBs, and these drugs work on the system I talked about, that angiotensin system in your kidney, and they are able to block that system so you're less likely to absorb sodium and your blood vessels are more likely to relax. Another type of drug we'll use are calcium channel blockers, and they help the blood vessels relax, but they also have a diuretic effect, and so you lose some of that extra volume. Diuretics, as you can imagine, result in you losing some blood volume. Not that much because they do more than just that, but that's a sort of simple way of looking at it. And beta blockers are different, another type of medication that slow the heart rate down, and they kind of block that ACE and ARB system as well. And they can kind of block the sympathetic reaction to stress. So those are the four different types. It's not important to remember, but just the next, if you have a medication, it's working on some component of that physiology going on in your body. So I want to kind of end my talk by just talking about, I mentioned the word phenotypes, which is a fancy word I said for variety. But so I like to break up hypertension in people whose BMI is less than 30, meaning they're relatively thin. And so if you have high blood pressure and you're relatively thin, most of those people have a very active renin system, okay? And their arteries are really tight. And in those patients, ACEs and ARBs work very well at reducing your blood pressure. Okay, those are thinner people. I always like to begin with a renin angiotensin blocker type medication. And for people who are uh, thinner, okay, it turns out that if you give them a diuretic, they're much less effective because the diuretic stimulates your renin system. So people who have a higher BMI, remember those folks have more blood volume. They're absorbing sodium a little bit more than they should, so they got all this increased volume, and these diuretics target your kidneys and allow you to get rid of some of the excess sodium. Folks of African descent tend to have less active renin systems. We call that a low renin state, and they tend to be a little bit more salt sensitive. So we typically would start with a diuretic or a calcium channel blocker for those folks. So I always like to close my talk with a quote, and this comes from Bertolt Brecht, the German playwright and poet. He said, "The chief cause of poverty in science is imaginary wealth. The chief aim of science is not a door to infinite wisdom, but to set a limit to infinite error." And I like to always close my talks with just saying, medicine, what I try to do is sort of demystify what I'm actually doing and not make whatever the disease you're talking about, whether it's hypertension or whatever, is to explain it to them and not to have them be overly concerned or scared, but appropriately uh, ready to address the issue. So thank you very much for listening.
All right. Well, thank you, Dr. Cummings, for your time and expertise during today's On the Pulse session. A fantastic presentation. And hello, everyone. My name is John Rickards, and I'm the Digital Education Program Manager here at the Minneapolis Heart Institute Foundation. And we'll just be jumping on here to help facilitate the Q&A portion. So the questions that we have prepared today were all submitted prior via the registration process and other outlets. So thank you very much to our registrants who did submit a question. However, please also feel free to add additional questions using the Q&A pod, which is located at the bottom of your Zoom screen, as these may be addressed in future On the Pulse sessions. All right, so Dr. Cummings, the first question that we have for you, this audience member submitted, what are the signs that my blood pressure is dangerously high and needs emergency attention?
That's a good question. That used to be a problem back in 1967, uh, meaning that when people's blood pressure could get up to like 250 over 130, you would get symptoms like headaches and you could be short of breath. But nowadays, most people do not have any symptoms from their elevated blood pressure because we're not seeing people walk around anymore in our country with that the level of high blood pressure. You have to achieved to have symptoms. It just doesn't, we don't see that. I've never seen a medical emergency related to hypertension ever. Now we have things called hypertension urgencies where they'll come to the ER and their blood pressure is relatively high and everyone panics. But even most of the time, those are occasions where the patient was there for other reasons and their blood pressure was fairly high. And so theoretically, you would be short of breath or you'd have headache, a pounding heart if your blood pressure was too high. But quite honestly, that's not really a common occurrence anymore in our countries. It's basically a silent disease in our country.
Thank you. Thank you very much for that. Yeah, that's really interesting. The next question that we have has to do about stress. And the question is, how does stress affect my blood pressure and what can I do to manage it?
Stress is a difficult to measure that, number one, and its impact on blood pressure is difficult to measure as well. We do know that acute stress, if you're anxious, plays a huge role in elevating your blood pressure at the moment. That's why we have that thing called white coat hypertension. That's why when you go to the doctor, your blood pressure may be falsely elevated. And that's why we like to do 24-hour blood pressure measurements because it, it, your blood pressure is very labile. And in fact, the older you get, the more labile it is, meaning it can go up at a drop of a hat. Yet over the 24 hours, it might not be a reflection of what's going on. So to answer that question is stress in the acute situation plays a big role. Stress overall is a harder to know how big a role that plays in hypertension. We like to blame everything on stress, and maybe it plays a role, but I don't think we actually really know how much. We do know if one relaxes and really chills out, their blood pressure will go down for that moment. But what does that mean over a day and that type of thing? I do think that what I tell people is that I think it's probably over exaggerated in terms of the long-term effect. Meaning I have plenty of patients who are very chill, never get excited, and they have very high blood pressure. I have type A people who are anxious and nervous, and their blood pressure is stone cold normal. So I think its biggest role is in acute settings.
Okay. Yeah, that's very interesting. So thank you very much for that insight. So this attendee is asking about hydration and the impact that hydration has on high blood pressure.
Yeah, I'm not really aware of hydration playing a role. If you get dehydrated really a lot, I think obviously your blood pressure might go down. But I don't think of hydration playing a big role I know that's with all these people working out and all these drinks and stuff. But I don't think we really know the status of hydration and one's blood pressure. I don't think of it ever being a role, quite honestly, in terms of causing hypertension and whether I don't know if there's such a thing as overhydrated or underhydrated, but I don't think of being a big player.
Okay, interesting. And thank you very much for that. So this attendee is asking, so if someone is diagnosed with hypertension and is receiving drug therapy, does that typically mean that these patients will be on a lifelong medication, or are there opportunities to improve it so that they no longer have to take their blood pressure medication?
I like that question, and I get asked that a lot. And the truth is, most of the time, it means you're going to be on it indefinitely. But there are exceptions. If somebody is on high blood pressure medication and they're overweight or significantly overweight, if they were to lose weight, their blood pressure might completely disappear. And I've had that happen to a number of patients, but you have to be probably significantly overweight. Um, if like I mentioned already, alcohol, if someone's drinking, excessively and their body's sensitive to it, that would, if you were to abstain, that would help. I think of exercise probably being a mild one. It'd be more in terms of what can you do differently to get off meds? I suppose exercising, getting in wonderful shape would be a good thing, but I think that's going to have a less of an impact than someone who's overweight or somebody who's drinking excessively. But most of the time, the people I see, they're going to be on indefinitely. And what I try to do is we have a way of always blaming the patient is that this is genetics and it's age mostly. And so just to kind of just to let them know that you just try to live a life of moderation and it's just one of those things we just treat and we're lucky we can treat it.
Yeah, absolutely. Makes a lot of sense. So thank you very much for that. So let's just do a few more. We are coming in at the end of our time here. So let's talk about, let's see here. So this attendee is asking about supplements, specifically supplements containing beets in blood pressure management. They say there's a lot of advertising for things like super beets and so on. Do you have any insight into supplements in general, but specifically supplements containing beets?
Yeah, that's an interesting question because beets. Remember, beets have nitrous oxide. Remember that equation? So nitric oxide helps dilate your arteries. So in theory, that could work. And I think there's some studies that show that, but unfortunately, the impact is very modest. Okay, and so I mean, I actually did. I don't like beets, but I actually took a supplement with beets because, but to see if that would help. And I think that it does have a role, but it's very, very modest. Uh, and there's a thing called whey protein, which is really good for building up strength. And there's some evidence that whey protein supplements lower your blood pressure. And whey protein, it's interesting. It's a product of milk, and when you try to make cheese, and whey protein's a different part, whatever. But that it works on that system I talked about, the angiotensin system, and it results in a drop in your blood pressure as well. So yes, there are things you can do. They're just not quite as effective as medications. And the original study that was done is called the DASH trial. It was a number of years ago, and it showed if you were on a ridiculously low salt diet, you could lower your blood pressure a modest amount. But it's just not that sustainable to do that for very long. So I just say the biggest thing is just sort of moderation. But I think whey protein potentially is probably the biggest one, but there's probably some role for beets as well.
Definitely, definitely. And thank you very much for that insight. So let's switch gears here a little bit and talk about research. You had mentioned some research that you had done previously in your presentation, but are there any upcoming research studies that you are excited about?
Well, I, I'm kind of interested in the 24-hour one, studies related and what one of my little interests is we all have this sort of circadian rhythm, meaning that your blood pressure is not the same throughout the day. And I normally uh, throughout the day it's sort of up and down. And then when you go to sleep, your body actually relaxes and your blood pressure goes down typically about 10 to 20 points. And there's some evidence that if you were to take some of your medications at bedtime, particularly the medications I talked about, ACEs and ARBs at bedtime, they tend to be more effective because that's when your system is revved up. And so we once did a little trial that showed that when a person took an ACE inhibitor or that type of medication at bedtime, it was more effective. But I'm not aware of, there hasn't been any new drugs for quite some time. But my own personal interest is it would be the timing of when you give medications. Is there a better time to give it? And also, I think we'd like to know if we could actually get better at figuring out what kind of phenotype you are, what is the physiology of your high blood pressure, then we could better direct the therapy towards that. So that's where I'd like to see some of this stuff go.
Yeah, absolutely. And that's very interesting. And thank you very much for that. So let's see here. So if folks want to learn more about managing hypertension, do you have any resources or websites or anything that you would suggest?
I really don't, and it, I actually don't. But in this talk, I tried to cover the stuff that I thought would be helpful. And sometimes when you get into the weeds and you can kind of get lost, what I try to do is not make it that complicated and try to simplify things because that kind of gets at what we can do or not do. And so I don't really, you can look all that stuff up, but I sometimes think those some of these sites and these societies are overkill. And what I try to do is sort of demystify it and simplify it so that it doesn't become this sort of overwhelming thing and just focus on the things we can control and then and go from there. I guess so I don't really have a site that I'd have you go to.
Okay. Sounds good. So is there anything else that you'd like to say to our audience before we sign off?
No, thank you for listening, and I just want to let you know that I joined the Minneapolis Heart Institute Foundation about 6 months ago, and it's just been a delight. I'm so impressed with what they're doing here. And a long time ago, when I was a resident, I used to work with all the cardiologists back when there's like eight of them. So I've always had an interest in what you folks are doing here and the amount of research that comes out of here. So I just want to, show my appreciation for the foundation and what Chris and Scott have created. It's a pretty special place. So thank you.
Absolutely. And it's a privilege to have you on board, Dr. Cummings. So that's all the time that we have for today, folks. A big thank you again to Dr. Cummings for presenting on this excellent topic. And thank you to all of our attendees who joined us this afternoon. We appreciate your participation. Before we sign off, I just wanted to mention that our next On the Pulse session is scheduled for Wednesday, May 21st, featuring Dr. Kirsten Shaw. We'll be presenting on From Real to Real, What Can We Learn About Hollywood Heart Attacks, which is a presentation giving insight into how heart attacks are portrayed in the media and the lessons that we can learn from that. So we'll go ahead and add a link to the chat pod now, which you may use to register, and we hope to see you there. So with that, thank you everyone and have a great rest of your day. Thank you.